Thank you, Dr. Sands, and thank you, Susie. I also want to thank the organizers for allowing me to come to speak to you today with the longest title, I think, for a talk here. So I'm grateful for that. I neglected to put in a disclosure slide, which is relevant. I have done some consulting work in the last 12 months for Janssen. I also have had some grant money from Genentech. Okay, use mouse pointer. There we go. So this whole concept of cancer in IBD and the impact of medications upon it is certainly something that we really have to pay close attention to as time moves on here. And I want to thank Ray for dealing with this in the elderly already, because given my 20-minute limitation, I wasn't going to be able to get to it. Medical therapy for IBD, we're using the anti-TNFs earlier in the disease course. We're seeing a greater advocacy for combination therapy when able, using thiopurines along with our anti-TNFs. We have these great, big, ugly black box warnings, which are kind of scary if you ever take the time to read through them on our prescribing information. And we have this aging patient population, and an estimated 1.6 million Americans who were diagnosed with cancer in the US back in 2013. We're going to be seeing this and see questions arising from this more and more frequently over time. And unfortunately, I'm here to tell you there really aren't a huge number of data that are out there to guide us. We can think about this in a number of different ways and I'm growing long in the tooth, so I need to put my glasses on now. I thought I could read that before. So there are a number of different ways that we can look at this question of cancer and IBD. And the first way we could look at it, or the first question that comes up, is does medical therapy for IBD predispose to the development of cancer? I'm largely going to be talking about that. But there are some other questions as well that we'll leave unaddressed now, some of which will be addressed in a combined symposium tomorrow. Is an active IBD patient with a history of cancer, in such a patient, does IBD therapy impact on cancer recurrence? And once cancer develops in an IBD patient, is the cancer outcome different? Is the treatment strategy different? Is there a different stage that these patients might present at? And finally, in an IBD patient with cancer, does the cancer therapy affect the outcome? And so as I mentioned, we're really going to focus on this first question in today's discussion. Though I welcome questions on the other later on. And so I have a couple of slides here that are going to, very, very broad brushstroke way address this issue. And this first comes from really a series of Danish population registries that were combined. And we're able to ask the question whether or not there was an increased risk of malignancy with the use of thiopurines. And you can see that azathioprine or thiopurine users had a rate ratio of 1.4 that was statistically significant, but that former azathioprine users did not. And this was in a population-based study of over 46,000 patients with IBD, 5,197 who were on a thiopurine, with a median of 7.9 years, patient years of follow-up, and the development of just over 2,500 malignancies. But there's a little bit of silliness that kind of goes with this, because this overall question of cancer, we're really talking about so many different diseases, and we really need to keep that in mind, and we would like to be able to separate these things out into specific illnesses when we can. We can take a look at the randomized controlled trials for anti-TNF use, and there's a meta-analysis that's out there that summarizes all the effects of these randomized controlled trials, truly the proper way to do a meta-analysis. And Williams and colleagues found, and you can sort of see on this, that the bottom of the forest plot shows that there's really not much of a difference. If anything, there might even be favored anti-TNF use towards preventing cancer. And we've seen data like this where there's been no statistical significance in a number of different situations, including the TREAT registry over time. And we saw this again and again, the combined Danish registries where they can link the pharmacy registry with the diagnostic registry, with a cancer or tumor registry that's out there. And what you can see all the way over on the right, I don't know that it projects well enough depending on your visual acuity, that very last column is the adjustment for azathioprine use, and there was really no difference at all. So overall cancer, not much of an increased risk as far as we can tell, but we kind of know a little bit different at this point in time. So what we have seen in the extra-intestinal cancer space is some suggestion of an increased risk for lymphoma, a certain increased risk for skin cancers as well, both the non-melanomatous skin cancers as well as melanoma itself. There's been some conflicting data on cervical cancer that's out there that I'll talk about, and this increased risk in urinary tract cancers as well. And what I'm going to be able to do, because the charge of this talk here was really to make this as practical as we could, or as I could, and so I'm going to come up with some suggestions on how you ought to be thinking about this and what we should all be doing in our practices. So lymphoma. There are a number of known risk factors for the development of non-Hodgkin's lymphoma, which is by and large what I'm talking about here. Most immunodeficiency-associated lymphoproliferative disorders are diffuse and large B-cell type, often arising in extranodal sites, including the GI tract and the brain. And we believe that most of these are due to a defective immune surveillance of EBV. These are really, to some extent, first appreciated or first well appreciated in the post-transplantation literature, and then again in a number of immunosuppressed diseases for folks who are using these agents, including things like rheumatoid arthritis and lupus and others. So the risk is increased in older age, in men, in those with a longer disease duration, and those who have immunosuppression from azathioprine, among others. And azathioprine has a variety of possible mechanisms of actions, and what we can tell in looking at this complicated figure here is, and this will become, this particular mechanism is really only relevant in skin cancers for later, but what we have here is impaired immune regulation of the tumors and all of these different after effects of the use of azathioprine or 6-MP as the thioguanine nucleotides are subsequently incorporated into the DNA. And there's really a number of different ways that a lymphoma can occur. And what we see really are three large categories of lymphomas in these patients. One is the post-transplant-like lymphoma that's out there. And these are really patients who are EBV positive, and the risk can be as high as 1 in 1,000 patients, and even higher in the elderly, as Ray has pointed out to us. There's also the early post-mononucleosis group of patients, and these are younger men by and large, less than 35 years old, who come into their therapy EBV negative, and while on therapy develop an EBV infection. The rate is an order of magnitude lower, blessedly, but this is particularly a big challenge. And then finally, there's the hepatosplenic T-cell lymphomas that we've come to grow familiar with, and there's more than an order of magnitude of us in here versus those who have ever had this illness in the modern era. These are young patients, mostly men, and on thiopurines and anti-TNF combination therapy, or thiopurine therapy alone for at least 2 years, and you can see that rate of 0.05 per 1,000 patient years, very different. So the Danish population registries did go on, despite my little teaser there before, they did go on to take a look at this question of lymphoma specifically, as opposed to just reporting on their overall cancer rate. And you can see here that the risk for azathioprine users was 2.4 times the baseline risk, with a 95% confidence interval ranging from 1.1 to 5.1. And so certainly an increased risk, and something that we have to be conscious of as we prescribe these medications. There have been a number of really great studies, a number of meta-analyses that have been done, a number of population-based studies, a number of small single-center studies. They've really all almost come to this similar conclusion that there's somewhere between a 2 and 4 times increased risk of non-Hodgkin's lymphoma. And we can see that this has been subjected to a bit of an analysis, not just for azathioprine, but for the anti-TNFs as well. Corey Siegel's meta-analysis of the randomized controlled trials found a 3-fold risk, although taking out azathioprine reduced that risk to about 1.7, but there was certainly some overlap between azathioprine users and non-users in that group. Harrington took a look at the Kaiser Permanente registry, found a slightly greater than 4-fold risk with anti-TNFs, though this again was certainly complicated, or not complicated, but compromised by the co-administration of thiopurines, which couldn't quite be teased out. The Danish registry study that Anderson did, that I showed some data from before, showed that there was no increased risk when controlled for azathioprine use, which they're able to do. So it's still something of an open question as to just how potent an independent risk factor anti-TNF therapy is for the development of lymphoma in IBD. But I think it's best that we assume that it is, that it's somewhere in the general region of that same 2 to 3-fold risk that we've seen with the azathioprine or the thiopurines in general. So hepatosplenic T-cell lymphoma, about 200 cases in the literature. There were 36 cases reported not in 201, but in 2013. They are often rapidly fatal. 2011. They're often rapidly fatal. They are not EBV related, as I mentioned before. Greater than 90% occur in men and 90% occur in those who are under 35 years of age, which I think is young, but I am going longer in the tooth. All of these patients were on thiopurines at some point. Some were on combination therapy, so it's not clear if this happens on monotherapy with anti-TNFs. It's yet to be reported that way, but it's something that we all have our antennae up about, and we'll just see over time. So it hasn't been reported in the RA literature to any great extent in those on anti-TNFs and methotrexate, and that's worth keeping in mind as well. So some good news that's out there with lymphoma risk in our IBD patients, and that's that the risk returns to baseline after stopping thiopurines. In the same meta-analysis that Ray referred to before, you can see here at the bottom of this forest plot that you can see that the overall risk gets much, much lower than it had been afterwards, and you can see the relative values of this ranging from nil to as high as 2. And so it's really, it's quite impressive that we think of this as a 3 to 4-fold risk. That risk gets down to 142 over time after withdrawing the thiopurine. So certainly very encouraging news. So what can we do to help our patients? What kind of difference can we make? Well, what we should be doing, and you'll see this bullet point come up again here, is we need to have an open and honest discussion of the benefits and risks before we start. We have to really invoke a shared decision-making strategy. There are lots of wonderful tools that are out there. Corey Siegel's tool, as you're well aware, is out there. There's the ME Solutions group that's out there. But you really need to have a good discussion and educate your patients as you do it. You should be checking EBV status in your patients younger than 35 years old. And if it's negative, I wouldn't start a thiopurine at that point in time. You want to give good consideration to methotrexate whenever you can. Instead of thiopurines, though at least in the IBD literature, that combination therapy strategy isn't as well founded. And we want to minimize exposure to thiopurines whenever we can. Some recommendations, and certainly the ECHO group has done this and others have come up with it, is to stop after 2 years of exposure in men who are under 35 years old on combination therapy. And we need to await more information on withdrawal of anti-TNFs, and I thought Jean-Fred's talk this afternoon was really terrific in that regard. And we need to be considering other agents that don't appear to have, at least not yet, any association with a malignancy, though time will tell about those and whether it's the anti-integrins or some other therapies. So skin cancers, again, I'm going to go quickly through this because Ray already set this up for me, which was very nice. When we think about skin cancers and their associated medication risks within IBD, this figure, which came from an ECHO review on the issue, was very, very helpful, I thought. Thiopurines associated with a non-melanoma skin cancer risk, but not associated with melanoma itself. Methotrexate, no effect. Biologic therapies, or at least the anti-TNF therapies, are associated with a non-melanoma skin cancer risk in Crohn's disease, and certainly associated, although the data really aren't all that great, but we take it at face value and try to be cautious that they are associated with melanoma. Combination therapy is a bit of an open book with melanoma, but the effects obviously there on the non-melanomatous skin cancers. So this is what a squamous cell carcinoma can kind of look like. And can be terrifically disfiguring if it's on face and hands, can become very difficult. A number of studies out there, enough so that what we have is a nice meta-analysis here that demonstrates that increased risk, something about 3 to 4 times, or really it's 2.2. 2.3 times the baseline risk in the combined hazard ratio that's there from a number of these studies, many of which were in large population bases. The melanoma data, as I alluded to before, really not all that powerful. You can see two population-based studies where we've been able to look at this. Millie Long's study and that one of the Danish studies of anti-TNFs. You can see that Dr. Long's study showed an increased risk of 1.9, but there was no increase with the Anderson risk. And then the Nardone study that's down there that was published is based on an FDA adverse event reporting system that's out there, and with that there was an increased risk of 1 3/4 time the baseline. So I think that that's enough that we really do want to consider melanoma for our patients on anti-TNFs to be at risk for melanoma moving forward. So what can we do to help our patients with respect to skin cancers? Again, that same open and honest discussion of risks and benefits and a shared decision-making bit. You know, your patient who looks like Howard Stern's famed tan mom, this is a patient who, you know, maybe a thiopurine isn't the right way to go. Someone who's spending time in a tanning booth or on the beach and that's their thing, wouldn't bother to give. We need to counsel these patients about UV light and sun exposure, as well as the use of sunscreen, and we want to have an annual dermatologic appointment where they can have a complete skin exam on every year. We want to consider stopping thiopurines after after squamous cell carcinomas and basal cell carcinomas develop. So cervical cancer, it would be nice if this was a clean bit of data. Cervical dysplasia and cancer, second most common form of neoplasia worldwide. There are known risk factors, obviously HPV infection, which is sort of a necessary cause, and many of the rest of these go with either progression or acquisition of HPV, prolonged combination oral contraceptives, multiple sexual partners, parity, early age at first intercourse, which I was happy to find out meant less than 20 years old. I am, after all, the father of 3 daughters. Co-infection with other sexually transmitted diseases, and then the immune suppression that goes with it. That goes with IBD is a potential one. And so with all that in mind, there is this business of a number of different disease states in which there is an increase. So lupus patients who are on cyclophosphamide are at an increased risk. There's an increased prevalence of this in rheumatoid arthritis, increased incidence in post-transplantation, and an increase in patients with HIV. And so it begged the question whether we could see this in IBD. And so there's a bit of a mixed literature that's out there, some that have shown that there was this association with abnormal pap smears that were out there in IBD patients, and some with a consequent association that was detected with thiopurines. But there's really not a lot of consistency here, unfortunately, but I'm not sure that it necessarily matters, because this is a disease, terrifically, where we have a great screening tool and a great surveillance tool at our ready. And so again, as we have our open and honest discussion with patients and shared decision making, we want to be sure that they have good gynecologic follow-up. We want to be sure that our patients who are on thiopurines have twice pap testing in their first year after diagnosis and treatment, and then annually after that. And we want to give all of these folks HPV vaccination early on. So finally, urinary tract cancers. Again, the Danish group here was able to find an increased risk for urinary tract cancers, some bladder, some renal cell carcinoma, and interestingly, an increased risk of almost 3 times the baseline risk. And this was confirmed more recently. This just came out this week, in fact, in publication form online of the SESAM cohort, and you can see that really nice increased risk here of actually 5.4 times the baseline in our elderly patient. And Dr. Cross alluded to this earlier, or these kinds of findings earlier as well. So unfortunately, there's not a lot we can do in terms of prevention. There's no great established benefit to screening and early diagnosis in these illnesses, but we do need to keep them in mind when we're seeing our patients. There's really not a lot out there with respect to methotrexate, and I should say that there's even less that's out there in terms of our improved armamentarium in terms of vedolizumab. There are a few cancers in some of the pivotal trials that led to its approval, but we really need to do good vigilance, and it's not appreciated yet at this point in time as being an independent risk factor. So to conclude, there's an increased risk for lymphoma that's out there. We want to minimize unnecessary or excessive exposure. Think about stopping early and working with the new paradigms of stopping, particularly in combination therapy. With the increased skin cancers, we want to minimize sun exposure and make sure they get in the hands of a dermatologist. With respect to cervical dysplasia and cancer, we want to increase the IBD patient PAP exposure. Turns out we do a lousy job of getting our patients to their PAP smears. And we want to vaccinate against HPV whenever we can. With the increased urinary cancers, the only advice I have is just to stay calm, but be vigilant as you can. And finally, I want to thank you. This was a cake given to me by a patient who has had numerous squamous cell carcinomas on thiopurines. He's not on them anymore, but he brought this to our practice a couple of days ago. Sadly, I didn't get a bite of it. Bruce, I don't know if you did. Sorry, but this is Mount Sinai's official entry into the Cake Boss competition that will be part of our reception later. So thanks very much.